Welcome back to the podcast. I'm Dr. Khan, and today we're diving into the anatomy of the chest, but we're looking past the surface. We're talking about the hidden architecture of the breast, specifically the axillary tail and the retromammary space. Dr. Sarah, I'm ready for some high-yield gems today.
Happy to be here, Dr. Khan. These two structures are favorites for board examiners because they bridge the gap between general anatomy and clinical pathology. If you're a student, you absolutely cannot walk into step 1 without knowing the tail of Spence and the significance of that retromammary sliding plane.
Exactly. Let's start with the axillary tail. I always tell my residents to think of the breast not as a perfect circle, but more like a comma. That little tail at the top is the axillary tail, or Spence's tail. Dr. Sarah, how does the textbook define its boundary?
The precise anatomical fact to remember is that the axillary tail is an extension of the mammary gland that pierces the deep fascia of the pectoralis major and actually enters the axilla. It's the only part of the breast tissue that lives under the hood of that deep fascia, extending up toward the armpit.
And why does this matter clinically? Well, if a patient comes in with a lump in their axilla, your brain might immediately jump to lymph node or maybe a lipoma. But if it's the tail of Spence, it could be a primary breast tumor hiding in the armpit. It can also swell during the menstrual cycle or lactation, just like the rest of the breast.
That's a huge point. For the boards, they often ask about the upper outer quadrant for a reason. About 60% of breast cancers occur there, and the tail is the most lateral extension of that quadrant. If you miss the tail during a physical exam, you're missing a significant portion of glandular tissue.
It's like checking a house for leaks, but forgetting to look in the garage. Now, let's go deeper, literally. Let's talk about the retromammary space. Dr. Sarah, give us the academic lowdown.
The retromammary space is a potential space containing a small amount of loose connective tissue. It's located between the base of the breast, specifically the posterior mammary fascia, and the deep fascia covering the pectoralis major and serratus anterior muscles.
I love an analogy for this one. Think of the retromammary space like a layer of oil between two plates of glass. It allows the breast to slide freely over the chest wall. Why does this matter clinically? Because in a healthy patient, you should be able to move the breast independently of the muscle underneath. It's that slip and slide effect.
And when that sliding stops, that's a massive red flag. If a tumor originates in the breast and invades that retromammary space, it eventually anchors to the pectoralis major fascia. On exam, the breast becomes fixed to the chest wall. If you ask the patient to put her hands on her hips and push, contracting the pec, the whole breast will move with the muscle or stay rigidly in place.
It's the difference between a puck sliding on ice and a puck frozen in a block of ice. If it's stuck, the cancer has invaded the basement and is now moving into the foundation of the house. That changes the staging and the surgical approach immediately.
Speaking of surgery, the retromammary space is actually a surgeon's best friend. During a simple mastectomy or even when placing breast implants, this loose tissue plane is the natural cleavage plane. Surgeons can blunt dissect through this space very easily because there are no major structures crossing it, just small vessels and nerves.
It's the path of least resistance. Patients often want to know they have the best care, and as the doctor of choice, explaining that you are working with the body's natural anatomical planes to minimize trauma really builds that trust. If you know the space, the surgery is cleaner and the recovery is better.
Let's connect this to the suspensory ligaments, Cooper's ligaments. These are the fibrous bands that run from the skin, through the gland, to the posterior fascia we just mentioned. While the retromammary space allows for mobility, Cooper's ligaments provide the structural support.
Right, and when a tumor grows, it creates tension on those ligaments. It's like pulling the strings on a button-tufted sofa. When those ligaments get shortened by the tumor, the skin dimples. That peau d'orange or orange peel appearance is the classic board exam sign of lymphatic obstruction, but simple dimpling is often those ligaments being yanked backward.
Exactly. To summarize for the students listening, the axillary tail is the extension of the gland that pierces the deep fascia. It's still breast tissue. The retromammary space is the loose plane deep to the breast that allows mobility. If a lump is in the tail, it's still a breast lump. If the breast won't slide in the space, the cancer has invaded the muscle fascia.
Perfect summary. Anatomy isn't just a map of where things are, it's a map of how diseases moved. If you understand the tail and the space, you understand the spread of breast cancer. That's all for today. Stay energetic and keep questioning the why behind the where.
See you next time.